Welcome to Planetary Health First, Mars Next. It is going to be an amazing journey today. Hope you are ready for liftoff. We are live now. Well, I feel so privileged and special today. I'm going to get to it in a second. I am Michael Mann, host of Planetary Health First, Mars Next. I can't tell you where we are right now because we are somewhere in the universe. I'll leave it at that. But we are here with a special, amazing guest, John Gorman. And I've been chasing him, not stalking him, but I've been trying to find a time to land on Earth with this guy to get him on our show. And we got him today. And we are going to be discussing the state of social determinants of health benefits and Medicare Advantage. Why? Because he's been leading the charge. He's been the visionary on these things with all the Medicare Advantage work that he's done for, I don't want to say the amount of age or time,
no,
we won't get in it. Some 30 years of the making with his former companies. And so if you don't know much about John, I'll just say a little bit and then I'll let him tell you more because he knows himself way better than I'll ever. But John is an investor in social determinants of health. He's led some companies in this. One of his companies that he's done venture investing is Nightingale, and he can tell you a little more about that. But he, a few years ago, I believe, sold his company, the Gorman Associates Company, which really was I guess part of your legislative experience and the Capitol, understanding the dots of how this is going to work, what it would look like, and then bam, you just got up and got running and made this thing happen. So I'm going to segue to you, John, kind of share with our audience. I know many people know you, but those who don't, just a little bit about your background and let's get going.
Sure. Thanks for having me, Michael. Really, it's a thrill to be here, and I know we've been trying to connect for quite a while, but glad we finally made it together. I'm John Gorman. Thrilled to be with you. I'm back here at home in Washington, D.C. And just by way of background, as Michael pointed out, in my 35 years here in the Capitol now, I started here working out for my hometown congressman from Detroit, John Conyers. Came to run his congressional office, then went to work for President Clinton. And we set up the first Office of Managed Care in what was then the Healthcare Financing Administration, which is, of course, today, Michael, CMS. Let me let my chief canine officer in here. Hello, buddy. And, we basically had to carve out of a fee-for-service agency a whole team of people that would be able to run the Medicare and Medicaid HMO programs in the early 90s. So that was sort of the big precursor for now where we see the program, Michael. And had you told me, back in 96 when I was there, and Medicare risk, as it was then known, was about 7% of the program, that we would be at 52% of all Medicare beneficiaries now enrolled in what we call Medicare Advantage, I would have told you were smoking something that's, not covered by Medicare Part D. It's just an amazing trajectory that we've seen. And similarly, and even more so in Medicaid managed care. I mean, Medicaid health plans now represent about 74% of all Medicaid enrollees. So we started a real a real trend and an office in the agency that would be capable of regulating it and overseeing it. And when I left, I came to start Gorman Health Group. It became the biggest consulting and technology practice in the country in Medicare Advantage and in Medicaid. And you mentioned, all the political and policy stuff, but the core of the business back then and where, we really made our bread and butter was in turnarounds and fixing broken health plans that were participating in these programs and, the huge consequences that come from being out of compliance. So that was really our bread and butter there. And we used that practice as sort of like an R&D lab to identify problems among several of our clients and then say, could we write a piece of software to fix this? Or could we develop an outsourced service that we could do this better than the plans? And we spun off about a dozen companies, one of which became Signify Health. which, as we all know, Aetna acquired last year. So I've been in this space for over 30 years, as you point out, and I've got the scars on my ass of a man.
You don't need to show us that here live, all right?
Not at all.
We'll take the figurative meeting, but I loved how you walked us through that, and I love how you said 1996, Clinton. I think we've heard that name before, but how CMS wasn't even the word CMS. That's phenomenal.
No, we were the Healthcare Financing Administration.
Yeah, and then the fact that you shared, I think was it 7% now to like the amount of
52% today.
Yeah, that's just unheard of.
Yeah.
So my gosh, to hit it at the right time. So I would say if anyone needs some luck on a mojo, it's you with timing. You must be the mother of all, the king of all timing with hitting an industry at the right time. So what are you doing today? You obviously know where the puck is. What are you up to today?
The important thing is knowing where the puck's going to be. Today, I'm still serving as chairman of Nightingale Partners, Michael, as you pointed out. That's our venture fund that invests in social determinants of health companies in their early stages. So, for instance, we've invested in food security and food as medicine companies. We've invested in non-urgent medical transportation, which is a board meeting I was just coming from in Philly last night. We invested in a company that does the PACE program. So that's the program of all-inclusive care for the elderly. These are basically adult daycare centers that are set up as nursing home diversion programs, really, with services that stretch into the member's home. We just opened earlier this year our first PACE site here in Washington, D.C., and we're really thrilled about how that's going. So we invested in these types of companies, and then we would collaborate with many of my friends in the insurance industry that have made over all these years to basically stand up interventions around these social determinant of health issues. So, we've got to say right from the top, Michael, as I always like to, that, social determinants of health are just 4 fancy words for poverty and racism in healthcare. And, they account for 60 to 80% of what we spend on healthcare in this country. And those effects are magnified dramatically among elders, of course, who have lived, a lifetime of poverty and suffer from, multiple comorbidities typically. And then, the hardening that occurs from living a life of poverty and racism, and that has cumulative health effects. And so typically anti-poverty initiatives in Medicare Advantage, in Medicaid, where we're serving dual eligibles and disabled people, these types of programs and benefits are hugely impactful. And, I got my start in this, when I sold Gorman Health Group, and I was goofing off for a year after, and, my wife was tired of me sitting around the house all the time. So I did a little project with some friends up at Geisinger, and, they were dying because they found they were spending $250,000 per patient per year on their unmanaged elderly diabetics. $250,000 per patient per year. I mean, it's just staggering, the cost of this disease, especially in these rural communities like where Geisinger serves in central PA. And they tried everything. Nothing was working. So we worked on the establishment of a food security service that would deliver medically appropriate meals to a pilot of their first 1,000 members. And what we found was that after 14 months, we had their average cost down from $248,000 per patient per year to $48,000 per patient per year. So net of the cost of the meals, wow, we saved, over $200,000 a year and per patient.
Yeah. And
the return on investment was 35x. And I was just like flabbergasted, because what else can you invest in this world that will get a 35x return on investment. So I was hooked, and that was it. And that's where the birth of Nightingale occurred.
And when was that? What was the year? What year was that?
Oh, I think we got started in, it was 2019.
2019. Wow.
Yeah.
That is just incredible. 35x. That sounds like a venture fund
expanded
dream.
that program to their entire Medicare Advantage population that's diabetic, and it's like one of the biggest things that they've ever done. And now they've institutionalized the whole benefit, so they have their own kitchens, they have their own fresh fruit and produce division. I mean, and they're crushing it. And that was like what made me want to be an SDOH investor.
Yeah.
So I serve as the chairman at Nightingale still. As you mentioned, we sold it last summer, but I'm staying on to oversee the legacy investments. And then I'm serving as advisor to a couple of companies. I'm sitting on 6 boards still. And at the moment, I'm working with Tony Welter's amazing company called Sync Care, CINQ Care. And Tony, as you may know, is a legend in our industry and basically was the architect of United's entire Medicaid business. His first 2 hires were Rodney Armstead, who was my boss in the Clinton administration. And his second hire was Rita Mills, who was my co-founder in Nightingale.
Wow. And
the company really specializes in full risk management and MSO services for health plans for dual eligibles. And we will basically take all the risk on a dual eligible population and guarantee a return and an improvement in quality for the services we provide them. So I'm busy.
So this is almost like Gorman 3.0. I mean, I'm hearing what you did in the beginning, kind of like full circle, but gangbusters on your new data, your new what's going on. Would you say it's kind of like a full realization of where you were?
Well, it's certainly an evolution. I really felt after, 23 years in consulting and technology development that it'd be really freaking cool to be the banker for a change. And that was, that was a really, really interesting, like 3.5 years with Nightingale. And, frankly, I think we made the right move given what we're seeing in the venture market right now. But, certainly for the evolution of the stuff that I'm really passionate about and where I think we see the greatest bang for the buck in terms of improving quality for, the most vulnerable patients in the system, I'm right where I want to be, and I'm having a blast.
Yeah, I'm really excited hearing what you're done and what you're doing. Tell me about mental health. We talk about behavioral health. Are there any things that you're seeing there involved in on that? Because that seems to be, in many ways, if you're not feeling well, I mean, I know social determinants of health, it's like, there's different, whether it's the WHO or, different organizations that have created the models. But it seems like well-being, mental health, if you don't have that, you don't have hope. If you're not connected as a social, and maybe I'm getting a little too out there on Mars right now, and I'll bring it down to you. Just if you could go on to that, if there's any segue with mental health and what you're doing with that with social determinants of health.
I mean, sure. It's such an incredibly broad subsector within our industry, and as it usually plays out among older Americans and really vulnerable low-income patients, especially the disabled, it's almost a whole ball game. One thing you certainly learn that a lifetime of poverty almost always gets you serious depression, and the blues are. And the blues, depression, not Blue Cross Blue Shield organizations, I think is far more prevalent among elders and disabled people than we've ever seen in surveys and polls. I mean, I just think there's so many folks, older Americans especially, that just feel like there's a stigma attached with talking about this and asking for help with mental and behavioral health concerns. And it breaks down into so many different spaces, Michael, that we had to really kind of be pretty thoughtful about how we looked at it. So we invested in companies that make therapists and especially social workers available to seniors. We've been big investors in community health workers, which are an incredible sort of non-clinical resource at the community level that their one job is to clear the rocks from the road and to get vulnerable folks the services that they need. And they are invaluable in terms of connecting seniors and disabled folks with these much higher prevalence of these types of conditions into the resources that they need. We've invested heavily in substance abuse treatment and, the various aspects of how you can do that both online and in residential treatment facilities. The one thing I really take great hope in, Michael, is that, both of my daughters now are college age. Mm-hmm. And the one thing that they see in their schools is just this incredible flood of these millennials going into psychology, wanting to go into social work, wanting to be doing counseling of all sorts. And it gives me some hope for what the workforce may look like in 5 to 10 years, recognizing the acute shortage of these types of professionals that we can avail ourselves of today. So, the primary issues that we're dealing with as we see it in this space, especially in the medically underserved communities where, the most vulnerable folks that, we really focus on is just increasing access to these professionals by any means necessary, if that's online, if that's even just, getting people together in an underserved community in a group session, if that's all we can manage at a church. Those things matter. And, the more and better you can coordinate around those things and to provide, safe spaces where these types of services can be rendered. I think that's really where the greatest impact can be found. We certainly threw a lot of focus into unhoused people because of the prevalence of mental health conditions among them, and really found some really cool and innovative ways of approaching unhoused and housing insecure people in need of better mental and behavioral health services.
Can you share a little more about the unhoused, some innovation there that I'd love to hear more about that.
Absolutely. I mean, we worked with a couple of different clients that had substantial unhoused and housing insecure in numbers of enrollees. And it really became an issue of who do we serve first in the greatest need and for whom we can deliver a solution to most quickly. Because dealing with homelessness, Michael, as you're well aware, it's a really intractable and complex issue in this country from many, many respects. I mean, on one hand, the biggest contributor to homelessness in this country is debt, which usually comes from utility debt or it comes from medical debt. And people get behind in these bills and they can't afford their rent or their mortgage any longer. And they end up couch surfing and living out of their cars. And then they end up on the street. And so our first imperative was to mine the data and identify the population in greatest need that we could help the fastest. And to our fascination, we found with one of our biggest clients on this, it was newly emancipated foster kids. And these kids hit 18 and their foster families put them out on the street and they have no skills, no money, no place to go. And in the market where we were working in, Michael, within 6 months, 50% of those kids were being trafficked, were addicted to opioids, or both. And so we said, okay, this is our group, and we're gonna really go hard at this group of kids first. So the solution we had there was, it was really at the outset of the pandemic. And anytime you're trying to deal with housing issues like this, Michael, it's always about the supply and the cost of the supply, which is the second biggest contributor to homelessness in this country, is that people just can't afford their rents and mortgages anymore. And the astronomical increase in housing costs in just the last 5 to 7 years has just been staggering. I mean, you really need to be earning well over $100,000 a year to own a home in almost any urban market today. So with these foster kids, the market was not going to allow us a very fast solution, given zoning and NIMBY politics and all the other shit that goes on, and trying to increase housing supply. But at the outset of the pandemic, Michael, the one folks that had a glut of space that was ready to go were long-term corporate hotels. And so we went to, Candlewood Suites, and we went to, a couple of the other chains, and we said, we want to take out a block of rooms for at least a 1-year lease. And they sat right up and they said, what are we talking about? And I said, we've got several thousand newly emancipated foster kids. They're 18, don't have substance abuse issues, some minor mental health and behavioral issues that can be dealt with on an outpatient basis. We'd want to block off this group of kids, and they will have on-site community health workers and a nurse 24/7 overseeing them like an RA in a college dorm. And in 2 meetings, we had a couple of thousand rooms to go and do this. And many of those kids are still in those rooms today, or have now, by now have cycled out and are, making their own way, or they've got their own housing now. And that program was an absolutely astounding success, because, and we figured we got about a 20x return on investment on this. Because otherwise, we were going to be dealing with thousands of kids hitting these ERs, kids hitting these homeless shelters, which were pretty horrible in the market we were working in. Most of them were going to end up on the street or couch surfing, and there were going to be just rashes of hospitalizations. We were going to see them involved in the justice system, and because this was a county-owned entity that we were working with, part of our ROI equation was, what is this saving the county and the city in terms of services, other social services, just by a housing first policy for these kids? So that was one example, and one that we were really proud of, and still working great today.
Wow, that's just so exciting. I love to hear that. So how did that come on the radar? Where did you find out about the need in that county, and how did that come? Do you have the idea?
The client came to us, and
wow.
They were like, we have 5 figures worth of unhoused people in this market. And we see all the research, just like you do, that shows that, you get these people into housing and they're going to cost you a whole lot less, because otherwise we're dealing with them in ERs, we're dealing with them in inpatient settings, we're dealing with them in nursing homes, and they don't want and don't need to be in those places. And so when you take a housing first approach, Michael, and then you wrap the social services around the housing, that's where you get, these astronomical results like we saw in that case.
So what do you think, and I know you can't answer this most likely, because when I do, I'm always learning, always asking questions. That's the only way I learn, is ask questions. And so especially when it comes to Medicaid and programs, it's so localized. And so I know, like the NIMBY, which is, I finally came to realize that term, because that's a lot of not in my backyard, NIMBY.
Everything.
But I imagine there's so much competition and lack of cooperation with locale and city and county, and so it's really, that to me seems like a big issue. And how have you seen that being resolved when it comes to these sort of opportunities, if you would, or barriers?
I mean, like we said, this is it's such a complicated issue, and when one of the biggest answers has to be to increase the supply of affordable housing, you're talking in most urban settings, Michael, you're talking at least a 4 to 5 year horizon. If you're building new space, if there's even space to build in. Now, in the markets that we worked in, like in Southern California, that are very crowded, extremely expensive real estate, the bigger solution has to involve repurposing government property. Like the city and county of Los Angeles has literally hundreds and hundreds of square miles of defunct army bases that could be turned into, huge villages for housing insecure people, or for, memory communities, like for older Americans who, need affordable housing in a communal setting will be the best thing for them. But this stuff takes years, Michael. And so in the immediate focus, I think it really kind of has to be around how do we use innovative ways like unused hotel space to make this stuff available for folks. There are health plans that are out there that are throwing millions of dollars on rehabbing, the defunct no-tell motel out on the edge of town, and they're going to spend $20 million on that to house 100 people. That's not cost effective.
So you're almost
immediately thinking into, long-term corporate housing, if that's available. One of the companies that I serve on the board of and that I advise is called Upside Senior Living. And these guys, this is a SaaS-based service that will evaluate any member in Medicare Advantage or in Medicaid for their housing needs. They will assign them, in effect, a community health worker who specializes in housing. And they will then hit their national network of affordable low-income housing and assisted living facilities to arrange a place for that person to land. And they can do this in a lot of cases within a week. And it's a very cost-effective means of managing somebody under a housing first policy. That first, you got to shelter them. All of this comes down to Maslow's hierarchy, right, Michael? You remember when we studied Maslow's hierarchy, it's the triangle, and
give me something to eat. Give me something to eat.
But
or give me oxygen.
The triangle is shelter and security. And that if you're not safe, if you can't sleep, you're never going to be able to be an effective participant in your own healthcare. So first house them, then get them food, then get them mental health services if that's what they need, get them job training if that's what they need, get them substance abuse treatment if that's what they need. And that's always been the approach that works best. But in the long term, the only answer here is, almost like a whole of government effort around affordable housing. And it's way beyond, the need is way beyond anything like HUD could do, even with subsidies.
I what I've heard from the way you're saying it, it's like really the Airbnb model. It's leveraging that excess capacity and connecting the dots. It's like Uber Eats or DoorDash. It's like use all the infrastructure and just get it right. And so I am just blown away and just really energized and pumped from hearing you talk about this, because I'm not getting old yet, because no one gets old, right? I mean, I'm not getting old yet.
I don't know if I can speak for you, brother. I'm definitely old.
All right. Well, there's a little bit of facetiousness in that, but I guess what I'm saying for what you're talking about here today is I can only imagine the audience as they listen getting pumped up, excited about participating in making our world, our country better. And participating in how we can engage the community. And I think so I'm hoping after this, we can get some resources to the organizations you're involved with, some of these programs, because I think it really is about first the awareness of other people just like myself or younger people that are hitting the work markets, because it seems like they need more people, not necessarily volunteers, but just more awareness of what I would say is new solutions for these new evolving problems. It's an opportunity, an area of maximum opportunity, and we are in the process of redesigning how we see what healthcare is. Healthcare is no longer the way we thought it was. It's not about going to the doctor anymore.
Oh no, I mean, and certainly, now that we've really affirmatively found that poverty and racism drive the vast majority of expenditures in healthcare in this country. I mean, listen, man, we are only here because our social safety net has more holes in it than Swiss cheese. I mean, if we had anywhere near the scope of social welfare benefits that some of like the Northern European Christian democracies have, like a Sweden or a Norway, you wouldn't see these kinds of healthcare expenditures like we deal with here in the US. It's just because, this country may be the land of the free and home of the brave, but it's also the country of fuck the poor. And that's a big reason why we're in this healthcare conundrum that we are now. Now, what we've been able to do is to figure out some innovative ways of financing and delivering these kinds of social health services that, frankly, the government should be doing. But we've had to find a way of following the money. And in the case of poverty, following the costs and figuring out how relatively easy and cost effective it is to deal directly with the effects of poverty and immediately or very quickly reduce the attendant costs that come with it. Everything that we invested in Nightingale and the stuff that I'm working on now, a community health worker is, that's going to be the job of the future. In a lot of this. I think that's going to end up being one of the highest head counts among health plans in the decade to come. And these are basically social workers without a license who know their community. They have, you're really hiring for a personality type for a community health worker. I've basically found the most effective community health workers we ever hired were church ladies, frankly. And, they're just lovely, big-hearted people. They love helping people. They've lived in that community their entire lives. They know how to help. And then you offer them a paycheck to do what they love to do anyway. It's fantastic. I think we're going to see a lot of that. But assigning a community health worker has been shown to save on average about $2,500 per member per year in healthcare costs. Food as medicine interventions reliably return, north of $3,000 per member per year minimum on most chronic diseases that are food sensitive, like diabetes or kidney disease. These are investable projects and companies that provide these services. And when you approach it from a value-based perspective, Michael, and you arrange the financing of these services in a value-based environment, and you say, we're basically going to take some of these shared savings that we've generated from dealing with poverty, and we're going to reinvest it back into these types of programs to serve more people next year. That's what enables the sustainable financing of these types of benefits in Medicare Advantage and in Medicaid. And, this week, ATI Advisory, which is wonderful think tank. They're actually my next door neighbors. And Tumlison, the CEO, is one of my next door neighbors, and they do amazing work. But this week they released their 2024 report on SDOH benefits, supplemental benefits in Medicare Advantage. And I got to say, man, there's some troubling numbers that we're seeing in this report. What was so encouraging for us and other SDOH warriors on this stuff for the last 5 years is the explosion of these types of benefits and services from just 5 years ago when they were first authorized and we started to see the first early adopters. And so, for instance, food benefits went from 100 plans 5 years ago to over 2,000 plans offering some form of food benefit this year. Well, what we're now seeing for 2024, Michael, is something troubling, which is those numbers are getting static. And in some cases, they're rolling backwards. Like we're seeing the number of plans that are offering in-home services to help with activities of daily living fell off dramatically. Like there was a 2/3 drop in the number of plans offering those types of services to members in home and community-based settings. Those are tremendously effective services. But what it says to me is that Medicare Advantage plans still have not grasped the clinical benefit of these types of services and benefits for their members. That these product managers, the general managers of these MA plans, very often, obviously, are still looking at this stuff as a marketing and sales tool and as a way of, inducing membership into the plan, but without regard for, if we structured it the right way, it would save us thousands of dollars on this population. And they look at it as a retention tool, but not as much as a weapon to help improve all the HEDIS measures and the member experience under star ratings. I mean, we spend a whole lot of time when we think about the member experience, which is 2/3 of star ratings now, Michael, in terms of what happens in doctor's offices. But the average Medicare beneficiary, Michael, goes to an outpatient doc on average about twice a month. Okay. So there's limited impact of the member experience in what happens in doctor's offices. Well, now think of a food benefit. Okay. And if this is a food benefit that you're getting, say, 5 days a week, and the food is shit, nobody wants to eat it, as a couple of the big incumbent vendors typically sell. I mean, look, I'll tell you a little anecdote. When my mom passed last September, I had to spend a whole day cleaning out her 3 basement freezers. And they were absolutely chock full of frozen meals that had been sent to her by her Medicare Advantage plan. They'd send her 2 weeks of this frozen shit every time she got out of the hospital, which was a lot in those last few years. But she wouldn't eat this stuff because it was terrible. But she was a depression baby, so she wasn't going to throw it away either. And so she had 3 freezers stuffed full of this stuff. And so first I tried to bring it down to the local food bank. They wouldn't take it because they said it wouldn't meet their dignity standards. And then I tried to take it to Goodwill. They wouldn't take it. I ended up having to dump this stuff in a landfill because nobody wanted it. After I took it to the homeless shelters in town, and they took as much as they could stick in a freezer. And that's sort of the state of the art of food benefits in Medicare Advantage, and it's terrible. A food intervention is only as good as the food. And if it's not culturally competent, if it's not edible, if it's not easy to prepare or consume, that intervention is just money going down a rat hole.
So as you were talking, I was listening to what you said with 2/3 of the stars ratings are coming from HEDIS, and most of that is from the doctors, the primary care doctor's visit. Is there, or are you involved, and I'm sure you know this, about the redesign or an improvement of care of the Medicare Advantage or CMS initiatives? That are they trying to get more of where that 168 hours or whatever, the 165 hours where the person's in the home? So why don't we look at those things that we can, is that the future of really getting the quality metrics where they're really showing how the plan's doing the engagement outside of the walls in their home?
That's my point about a food benefit. I mean, if that food benefit is terrible, think about what that does to your star rating, to the member experience.
Okay.
You know, everybody in Medicare Advantage complains about how dual eligibles are tanking my ratings, my star ratings. You can't make these people happy. Well, if you're giving them a meal benefit and it's shit food they wouldn't serve in prison, what do you think is going to happen? you got to give these folks stuff that, one, is culturally competent, that no matter what it is, if it's a transportation benefit, it's got to be convenient. It can't be confusing. These things have to be provided in a form and a manner that somebody who has maybe an 8th grade education and who has suffered in poverty their entire life can understand and can utilize to the ends that you need them to for a benefit like that to work.
So are the plans that really get it? I guess they're really using those community health workers / social researchers, anthropologists, like-minded, UX design. I mean, that really is a UX design, customer delight. Are there any good scenarios of them trying to really get it right? Because there's money. I mean, I hate to say it, the stars are what drive the all of it. So I'd love to hear anything that you're seeing or a way to get better at that.
I mean, look, we're already doing it in terms of marketing and sales materials. I mean, we have all this stuff translated into every applicable language that may be in a health plan service area. Mm-hmm. And I think a lot of care managers and some chief medical officers understand that we have to be able to provide social services as culturally competently as our healthcare services are. And, I think plans that operate in really diverse urban areas in particular get that. I think, they do what they can to make language lines available so that if, somebody's Cambodian and they need translation service in a doctor's office, they'll make that available. But the real state of the art is having a team of community health workers that speak Cambodian as well. And, the greatest advances in services to counteract the effects of poverty, Michael, are really not done by technology. They're tech informed. But generally, the stuff that works the best and has the greatest impact are those things that are very high touch, frankly, and that, folks need a helping hand to figure out how to get to this appointment, or, how do I go and apply for this benefit that I'm eligible for, but I don't have transportation to get to. One of the greatest innovations of the last several years that I just love is my friend Anna DePaula Haneke's company called Uno Health. And she's an old Google engineer, and she's got a whole team of nerds that have figured out how to develop an app that will help Medicare beneficiaries, Medicaid beneficiaries electronically enroll automatically in all of the social welfare programs that they're eligible for in the state in which they live. And so it eliminates going down to wait in lines at welfare offices or at the Social Security Administration or the post office, so that you can get a housing voucher, or you can get low-income heating assistance, or you can get a utility abatement program enacted for you. And I mean, she's got clinical trials that show that just doing this, again, saves thousands of dollars per member per year for members that receive a service like this. So just something that's a rare example of a tech solution that really does something hugely impactful against poverty's effects. But generally, it's going to be done in the home, in a community-based setting, by somebody who looks like that patient, who understands their circumstances with a shared lived experience. That's where you see the real magic happen.
No, that was great. Love, I just put up there for those Uno Health, super wicked smart. Any social worker would love that. Oh gosh, the resources just, it's plug and play.
I love that company.
Yeah,
they're doing amazing work. So that's one example. Upside Senior Living is the housing company I work with. Food company I work with specifically around food as medicine and food security is Epicured up in New York City. And they're just amazing. They came out of a direct-to-consumer company that basically was doing prepared meals for folks with like Crohn's disease and IBS. And in their first couple of years, they knocked up tens of thousands of customers in Manhattan, most of whom were like, stressed out stockbrokers. And they built this beautiful business around it. But they were gaining their members onesie twosie. And I went to Rich Bennett, the CEO, who's just a brilliant, brilliant guy. And I said, what if we went to a health plan and we got you a contract for 500,000 meals for next year? And he said, holy shit, let's go do that. And so we, in the development effort, it was, what are the main food sensitive chronic conditions among seniors? And now let's build out a menu and a solution for each one. And then getting all the clinical trials done. Like Rich just finished up some clinical research at University of Michigan and Michigan State around the clinical value of a food as medicine program for a GI condition and for kidney disease, for instance. And those are some of the new Jack SDOH companies that I think are, just doing bang up work right now. And if the plans could actually wake up and take a longer view than just 1 year ahead and see that the true value of SDOH benefits is in reducing the medical loss ratio and improving the quality of care that these folks get, thereby lifting your star rating and improving your clinical quality of care. That's where this stuff is at. These benefits are just being really wasted as a marketing and sales and retention tool only.
I know you shared about a chief medical officer that might get it. What are you seeing the plans that are getting it, that how their process is, that are evaluating these companies, the ROI, the keeping them, the making that selection? It almost seems like a company that did that as a partner, almost like like a third party.
Yeah, there were a lot of third parties that do this type of analysis that show these plans where to focus these types of efforts. In the big companies, this is typically what they call health economics or medical economics. Mm-hmm. And, I'll let you in on a dirty little secret, Michael. The chief medical officer is not typically the person who makes decisions like this on their own. The most powerful person in any of these health plans is the actuary. And the actuary is the one who will tell you diabetes costs us this every year. And it's the actuaries as much as anybody that have been reluctant to acknowledge the longer term health effects of these types of benefits and services. So, there's still a lot of convincing that has to happen out there, especially when we're seeing trends like we saw in the ATI report this week with, basically stagnation in these benefits across Medicare Advantage. I think that's upsetting and something we really got to revisit as we head on into 2025.
Yeah. Do you think part of the economic climate has just made a slash approach part of what you're seeing possibly in the ATI report, showing a lot of where you had 2,000 uptick of some really amazing social determinants of health, and now you've seen a lot of lowering that, just cost cutting measures, or what?
Somewhat. I mean, it's got a lot more to do with the changes in the payment rates that CMS pays them in the base rates. And, we are having the beginning of a real problem in Medicare Advantage right now, Michael, which is, we're over 50% of the program now. Mm-hmm. And the base rates that these plans are paid is basically a rolling average of the last 5 years of what fee-for-service paid on a county by county basis. And, and then they apply all kinds of little adjustments and factors to that. Mm-hmm. But that's the core of it. But now that we're over 50%, that's starting to cause some real volatility in these rates. And CMS is going to have a real come to Jesus in this next year or two to recalibrate these rates so that they're more stable now that the majority of the program is Medicare Advantage. So that's for one. Where you see economic effects is going to be in things like a transportation benefit or food benefit because of the inflation in groceries and commodities, and the price of gas is coming back down now. But I think a lot of plans hit the brakes, if you will, on a transportation benefit because it's really hard to do well. Round Trip, which is our portfolio company in non-urgent medical transportation, is a very different company than, say, an Uber or a Lyft, in that they are tailoring that ride service to the medical needs of the patient. Uber will basically just send, whoever's available. But the beauty of a company like Round Trip is they've run the data on the membership and they know exactly which member needs what type of ride. A single Uber driver with a freaking Prius is not going to be able to get Big Mama down from a 5th-story walk-up to get to dialysis 4 days a week and stay there with her for the 4 hours she's in that chair. That's what companies like Round Trip do. And they'll make sure there's 3 guys to get Big Mama down every day, and she's in an ambulette, and somebody is going to be there to pick her up as soon as she's done with her dialysis every day. That's a tough thing to do when it's not executed well. It's another one of these things where if it's a benefit that's in common use, regular, frequent use, nothing torches a member experience like a shitty transportation benefit or lousy food.
Yeah. Well, John, we're really coming towards the end. I don't want to get you barraged with inbounds, but I know just having you here and people seeing and hearing you, they're just going to be wanting to learn more. So what would be the best way to connect with you? How would you like, this is your moment to let us, our audience, know you and how we should proceed?
Well, my contact information is on my LinkedIn profile. You guys can reach me at john.gorman@nightingalepartners.org. That's usually the best way to reach me. And I'm active on LinkedIn, obviously. And I hope you'll check out Sync Care, the great new company I'm working with today.
Well, I need to put that up there because that's a spell. Is that it right there?
Yeah, that's it.
Okay.
Tony Welters, the legend. So, we kind of put our band back together and under Tony's wing, and we're having a good time out there.
So that doesn't hurt. So if you play good music, it could be a plus when working with John Gorman, right?
Oh, yeah, absolutely. Fellow musicians unite.
Nice. Well, this has been such an awesome time having you. And I would consider,
Michael.
I hope you consider me a friend. I consider you a friend, John, and everything you're doing. And this is a wrap up for today on Planetary Health. And thank you all for coming.
Thanks, brother.
Friends, it has been a great journey today on Planetary Health First, Mars Next. Follow us for more on Planetary Health First, Mars Next. Until next time, peace be with you.